We'll kick things off. Hello, everybody. Thank you so much for being here. Welcome to our June uh, state advocacy webinar. We've got a very good presentation for you today. We'll be discussing rare disease advocacy in rural communities. Just a little bit of housekeeping before we start. If you would like to ask a question, please feel free to type it into the Q&A box, and a member of our team will direct it to the panelists at the end. You can also use the chat as well. We'll be monitoring the chat too. If you're a member of media, we just ask you that you formally announce your participation and refrain from quoting any of the discussion during the webinar. We encourage members of the media to follow up with our panelists and presenters after the webinar for direct quotes. Our speakers today, we've got our very own Abby Hauser, who's our Associate Director of Community Engagement here at the Every Life Foundation for Rare Diseases. We've got Sky Collins, the founder of Oklahoma Rare, and Shay Linton, the founder and CEO of South Carolina Rare. Today, we're going to first start with Abby. We'll be talking about the Rural Health Transformation Program. Then we'll shift over to Sky to talk about rare disease advocacy and organizing in Oklahoma. And then we'll close it out with Shay to discuss rare disease advocacy and organizing in South Carolina. Then we'll take the audience questions that were in the Q&A portal and in the chat, and then we'll wrap up with some announcements. Without further ado, I'm going to pass it over to Abby to kick us off with our first topic.
Wonderful. Thank you so much, Syed. Like Syed said, my name is Abby Hauser. I'm the Associate Director of Community Engagement here at the Every Life Foundation. I'm on our patient engagement team, which really means my job is a lot of connecting you guys with resources, connecting your trainings, connecting you with skill building and all these sorts of different things, and then filling in the policy as well. So I'm kind of here under that lens of this policy, but rural health falls under what I'm really passionate about and what I'm working on. So today for state advocacy, I really wanted to highlight the Rural Health Transformation Program, which is a huge federal program that just we learned about last year. We're in its first year now and is really going to be, I think, an opportunity for rare disease advocates to maybe start engaging in their rural spaces because it's kind of what's moving and shaking right now in the rural world. Next slide, please. The goal of this program is, or of my session, is really just to learn the basics of the program. We're going high level. We're just talking the simple goals. And then I'm going to show you ways that you can locate how to find your state specific information just to kind of explore what it looks like, see what your state deemed important for this application. And it kind of helps shape what you see kind of moving and shaking in your state. And then finding ways that we can elevate these rare disease experiences within it. Next slide. So, what is this program? I know it's a lot of words for a slide. It was kind of hard to make a very pretty graphic for this, but essentially, the Rural Health Transformation Program is a federal program, which means it came from the federal government, giving $50 billion to approved states over 5 fiscal years. And that's just a financial year. So, really, just over 5 years. So, $10 billion is available each year, beginning this year, 2026, and it ends in 2030. That's a key part. Right now, is it has an end date. It is all we've learned is it's 5 years. There's no plans beyond that at this exact time. And how this money got shared was kind of a unique process. This is the biggest single investment in rural priorities from the federal government. So it's kind of new. Everything's a little bit different in how things have been done before. So the way this big chunk of money has been allocated, which just means how it's divvied up, 50% was shared equally among all the approved states. And then the next 50% was allocated by the Centers for Medicare and Medicaid Services, which is called CMS, based on a lot of factors. So they looked at like your rural population, the proportion of health facilities in your rural areas, certain situations of hospitals. And then this key piece is just any other factors that the CMS administrator finds appropriate, which is kind of interesting language, but it's really just more whatever they were looking at within your application, like how did the application fit in with the goals of the program and things like that. So that's kind of how the money was divvied up. And especially we've seen this first year, which you'll see in a little bit. So just keep those numbers in mind. We'll get into what that first year looked like in a second. Next slide. So really just big picture, I just took the strategic goals of this program right from the CMS webpage. And what this really is important to look at, like why we need to know what the goals are, is that this is how your states all took their applications to center around. Because when you're applying for a grant, when you're applying for money like this, you're looking at what the state or what the application wants. You're applying to try to get that money, so you're going to look at what the application is asking, and you're going to shape your program around that. So that's where you'll see some of these priorities for different states. You might be like, oh, that's, a little bit interesting. And they might have just put it in the program because it's a goal of this application and it helped them get money. So that's kind of how applications like this work. And it works like that across grants and things like that. But on a bigger scale, it just looks a little bit more obvious. So they're really focusing on things like rural health innovation, which is just like looking at preventative health, the root cause of disease, that kind of thing. Sustainable access, which just means like how can we create long-term access points? How can we make things more efficient in rural healthcare? And sort of how can we create centers that might coordinate with each other, how you might have regional things, just sort of all sort of care coordination within that was one of their goals. They want to work on workforce development. If you're new to the rural space, this is a big piece. The healthcare workforce shortage is a big rural health advocacy issue. So it is within this goal as well. We want to attract and attain a skilled workforce. That also impacts our rare community as well. And then these last two kind of go together. They want innovative care and technology innovation. So this is really the money's not meant to just go to hospitals that were already existing. They want it to go towards new programs that might innovate care, create something new, do something different to try to transform the rural health landscape in the state. So you might see some AI applications within this program. That was another piece of this tech innovation. So states applied with goals with that in mind. So you'll just see some things like that within it. But again, they were all looking to meet these strategic goals, and the applications had a bunch of other, things that they had to meet in order to potentially get a good chunk of that money as well. Next slide. So as we've seen, year one is already in effect. So 2026 is already occurring. And this article from KFF really took the money and split it up by the money per rural resident. So every state got different money. You might see like, oh, Texas got a lot of money, but they have a lot of rural residents. So when you take the amount of money that they got, divide it by rural residents, Texas is a state that got less than $100 per rural resident. So you can kind of see the way that this money was divvied up is a little bit interesting. It's not, quite every state's getting the same. It's not the same amount for rural residents. Some states got over $500 per rural resident. There's just sort of a lot of different pieces to it. And again, it's the first year this program has existed. We all learned when the money came out what that looked like. But this chart I just think is really important to kind of keep in mind in that, one state might seem like they got a lot more money, but they have a lot more rural residents. So they're working in a higher rural population. So that money's not going to go quite as far as it would with other people. Next slide. So now, like, what can you do? Like, that's a lot of information. You're like, great, my state got money. That's their program. Other people are doing that. But there's room for you to learn and room for potentially for you to find where that rare disease connection is. So there's an organization out there called the National Rural Health Association, and they basically are kind of like the Every Life Foundation, but for rural. So they do health policy. They're really great at the health policy angle, like elevating advocates, teaching you to train on rural health policy education, just all sorts of things. Their website is great, but they've taken this entire program and put it into one comprehensive website. So with the National Rural Health Association, its website, you can click around. You can click on your state. You can see what applications are currently open. You can see the contact information for each state's program. You can see just all sorts of different things. And Kenley will drop those links in the chat for you to head to. But this is a really cool resource and something that I think I challenge you at the end of this just to kind of check out towards the end. Next slide. So when you click on that, you'll get to a page. Every state's different. I picked Kentucky. I used to live in Kentucky. So I just kind of went through their maps. I clicked on their link, and it took me right to their Team Kentucky webpage. They have a whole bunch of information on what this looks like, all sorts of stuff. But this is kind of a really wordy way of looking at it. They have their full application, all sorts of things. But this is what one page might look like. And if we go to the next slide, we'll see an example of another state. Montana created their own website just for the Rural Health Transformation Program. A lot of states are doing that. If you see this little blue logo with the heart and the windmill thing, that is the National Rural Health, or that is the Rural Health Transformation Program's logo. So if you kind of see that attached to like your state or an effort somewhere, you know that that's kind of working within this application. So Montana was a great example. The Department of Public Health and Human Services is who is operating this program, but then they made their own web page. So you can kind of figure out where in your state is who's hosting it, who submitted the applications, and you can kind of see what they've put together for the community. Next slide. And if you don't want to read all of that, the Centers for Medicare and Medicaid Services have also put together a quick summary document as well that Kenley had just dropped in the chat. That is a summary of everyone's application with a lot less words. So it gives you the executive summary, the goals, the spotlights, the expected impact, especially, and this is, year one, the goals. And then you can see how much money they got. So Kentucky for fiscal year 26, which means it's this year, they got $213 million. So you can kind of see that quick summary. You don't have to know anything else beyond that. So kind of play around, see with what access you want. All of these can be linked from that National Rural Health Association page as well. But this is a great visual if that really is more your cup of tea. Next slide. So, like I said, this one stop shop essentially is going to be where you can click around and then get to your state stuff. So they have an information directory. They have your full abstract. So an abstract is like a summary of a grant application, or an abstract of a research article is a summary type document. So they have that available too. So if you want to read a little bit more long form, but not the entire application, you can also look at that for your state. All of this is very public information that you can be reading and learning about. And then interactive maps. I know I just met with a group and everyone was really into interactive maps and how we can map things and find this data. They have a ton of great maps on their website as well. So I would highly recommend clicking around there. Next slide. Okay, so this is kind of the big piece. It's like, okay, great, that's rural. There's a ton of different pieces moving and shaking in rural. Where does rare disease fit in? None of these plans are putting rare disease in their plan specifically. But that doesn't mean there's not a chance for you as a state advocate to figure out where your voice and where your rare disease population can be elevated in these efforts. So within all of these applications, telehealth access is a huge piece of this rural health transformation program throughout almost every state. It fits under the technology innovation, it fits under the innovative strategies. There's just all sort of categories that people have decided telehealth was a key factor. So you can bring the rare disease voice into that. You can say, we need them for specialists. Is this policy covering rare disease? Is your program, including our like really far out of state specialists? Are we working on broadband access? Like all just sorts of things that you can bring that rare disease voice into. Workforce shortage, we kind of touched on that earlier. If you don't have a primary care, your diagnostic odyssey is going to be so much longer for anyone else. So the workforce shortage really matters to the rare disease community because it will shorten that diagnostic odyssey. So you can bring that lens into it. If you're in a meeting or in a webinar for your state's program, you can just say like, hey, have we considered the rare disease perspective, or how does this work in this context? Or I have a patient that I know that experienced this. How do we lower that barrier? That kind of thing. Dental access, a lot of diseases actually do impact like your teeth and your mouth, and dental access is a huge piece of this program. You can bring that rare story into that. Just start elevating where rare disease fits in. It's kind of going to be how we're bringing this into it. So it's a big rural program. We're trying to just make sure that rare disease kind of stays a little bit on the radar, or that no policy created accidentally leaves behind your rural rare disease community when you're advocating for them. Next slide. So my challenge to you, again, totally optional, but just kind of in your own time, click on that National Rural Health Transformation Program page, explore the interactive map, head to your state's program, click around, read about a little bit about it, and just kind of see what your state has deemed the most important or the most pressing matter for this program specifically. And then just start thinking about those rare disease connections. Whether you act on them or not is up to you. But just start thinking of those links. It's a lot of equity at like advocacy falls into thinking of where we can bring the intersectionality into the conversation in places that it already isn't. So just start thinking of those critical connections. And then, if that does really interest you and you really want to be able to elevate those voices in your state, sign up for the state's group that's leading the program, whether it's your Department of Health and Human Services, your public health department. Figure out who is leading it, get on their email lists. They might have webinars, just attend some webinars. You don't have to, go all in, but just kind of stay informed, engage a little bit. That is a new avenue of state advocacy in this sense, because public health is usually very rural. It's a lot of just other disease areas, not always rare disease. So just sort of learning a little bit more about different programs that work in your state is just going to be a really great way for you to just start elevating and learning a little bit more about what rural might look like in your state. And with that, we have two other incredible speakers that have way more experience than I do and will be great at explaining their experience, their stories in their states. And I hope you're looking forward to hearing from them as much as I am. But on the next slide is my email. Feel free to contact me if you're interested in any of this, anything rural. Feel free to reach out to me. It's ahauser, which is Ahauser at everylifefoundation.org. And I'd be happy to chat. Thank you so much.
Thank you so much for that wonderful presentation, Abby. If y'all have any questions for Abby, feel free to use the Q&A port functionality at the bottom of your screen or drop those questions in the chat. For now, we will move on to our next speaker, Sky Collins from Oklahoma Rare. I'll pass it over to you, Sky.
Thanks so much. Thanks, Abby, and thank you to the Every Life Foundation for inviting me here today. So I'm going to talk about rare disease advocacy in Oklahoma. And as you can see on the slide, if you know Oklahoma, you know we're a really divided state. So I honor both our burnt orange and our OU red. So next slide. A little bit about me and my why. I'm mom to Lauren, Emma, and Presley. Our youngest daughter was diagnosed with Milan syndrome after an 8.5 year journey. Our family started Oklahoma Rare in 2022, and from our experience came the mission that no family in Oklahoma should have to wait that long for community to be known, supported, or understood, and that no Oklahoman should have to be their own expert in a system that should already know them. And that's my family on the left. Next slide. So we'll get into some rural stats, and I say stats. I have to say rural. It's a little hard sometimes for Southerners to actually pronounce, but I will say stats because I'm not going to go there in Oklahoma. So number one, rural Oklahoma makes up about 34% of our state's population, but accounts for 98% of its land area. Oklahoma ranks as the fifth worst state in the country for health professional shortage areas, with over 1.2 million residents living in areas with severe primary care shortages. So that's not specialist shortages, that's primary care. Oklahoma City and Tulsa. So in the middle of the map, Oklahoma City is in the map, Oklahoma City would be in the middle. Tulsa is in the northeast. They are our two major metro areas in Oklahoma. A patient in Texoma, to put that in perspective, will drive 4.5 hours one way to see a specialist or primary care provider in Oklahoma City. Next slide. In March of this year, we held our first ever Oklahoma Rare Town Hall. It was an amazing experience, and it was really a platform for Oklahomans navigating Rare to talk about what keeps them up at night, the barriers they're facing, and also what's working well. So this slide really talks about the gaps in the system that were identified as priorities during our first Rare Town Hall. So number one was access to care. So that would include both prior auth denials, also physical access to care. And when we talk about rural health, we talk about clinics that may not have equipment to weigh someone who's using a mobility device. So it's those kind of simple, when we think about it, simple but important physical access needs. That was a top priority for our community. And then of just of course, rural access to care in a general sense. Provider shortages and long wait times in Oklahoma. We are lacking some pediatric specialists completely. We have one pediatric rheumatologist in the entire state. But then we have a Medicaid legislation that says Oklahoma Medicaid will not pay for a provider out of state if we have a provider in state. So it's a challenge that rare families are currently facing, and in rural, that's really happening more often. Provider knowledge for complex care and rare disease in Oklahoma. mental health resources for patients and caregiver family isolation, delayed or misdiagnosis, lack of coordinated pathways, and insurance barriers. So these are all things that we really see across the state, and many of you as we're advocates see as gaps in the system. Next slide. But we really dug in and talked about gaps in the system that are really relevant to rural Oklahomans. So the top priority or the top one identified was distance to specialty care and the invisible travel burden. So not only do we talk about cost to travel to care, but we talk about time taken off work if you're driving 4.5 hours one way for an appointment. We talk about lack of coordinated care. So you're coming all that way for one appointment instead of a multidisciplinary clinic. We talk about childcare for our other children. There are a lot of things tied into that invisible travel burden. A severe shortage of genetics and rare disease informed providers, limited access to clinical trials, the digital divide, lack of rural specific rare disease policy. This is a big one we're going to see coming up in the next year is really lean staffing and funding in rural public schools, and then transportation and Medicaid logistics. So most rare disease systems are built assuming proximity to academic medical centers, stable transportation, broadband access, flexible employment situations, and rural Oklahoma. Uh, you're typically not going to see, we cannot make those assumptions. They will live outside of those assumptions. Next slide. So this was a really important slide to me to add in because I want everyone to hear what rural Oklahomans are saying. The first quote was, "Sometimes the messaging suggests that no progress is happening in rural Oklahoma advocacy. Across our communities, organizations, advocates, families, and individuals are working every day to create change and improve access." Another quote is, "I'm torn when it comes to in-person visits in Tulsa because there's a risk our daughter having a seizure while traveling. Services that come to us at home and telemedicine sometimes feel like a better solution, but it's conflicting." Another quote, "Families in our community downplay diagnosis and symptoms because of barriers and also the stigma attached to disability that we sometimes still see in our small community." And finally, families in rural Oklahoma are already traveling long distance for healthcare. Advocacy often requires traveling long distance too. So on this map, you can see each little dot is where our federal legislators' Oklahoma offices are. So basically, one whole quarter of the state, there is no access to a federal legislator's office when they're in town. So that's an access point that we need to think about as advocates. Next slide. So this is some of the good stuff. Policymakers are recognizing rural matters, and it's because of advocacy. It's because of rural advocates and advocates in general bringing rural to the front of the conversation. So Oklahoma House Bill 3066 was our Healthcare Workforce Training Commission and creating the Workforce Talent Recruitment Revolving Fund. That's a really, really important piece for Oklahoma, and we're thankful for that bill having been signed by the governor. Record state funding. So mobility management, when we talk about rural, we really have to talk about transportation. Recently, I heard a statistic that in Seminole County, Oklahoma, 1 in 4 families have no access to transportation. This is a rural county in Oklahoma. There is no public transportation, and 1 in 4 families, so 25% of that county, have no access to transportation. So we had record state funding this year for mobility management, which is a Federal Transit Administration funded program. It focuses on meeting community transportation needs, and they're doing amazing work in the state. And they had record funding, I believe it was $2 million this year. So that was really exciting. And then Abby talked about the Rural Health Transformation Program. Oklahoma secured more than $223 million for that, which also on the map, I think it meant about $100 per rural resident. So Oklahoma is really focusing on systems that exist and how we make them better to make the most of that money. So there are a lot of good advocacy opportunities there. And then Oklahoma Senate Bill 1132 appropriated $7 million from the statewide recovery fund to the Rural Hospital Rebuild Program. So we saw some good legislation around rural this year, and we will be advocating and watching for that next year. Next slide. And I want to leave you with this. Rural rare disease advocacy in Oklahoma is already happening. The question isn't whether it's happening or exists. The question is whether our systems make it easier or harder to be a part of it, especially for families who are navigating distance, access, and limited infrastructure at the same time as complex medical needs. And just as important, how do we become a part of the solution? So I want to introduce you to my friend Blakely. This is Blakely. She lives in rural Oklahoma. She is 7 years old and diagnosed with a rare disease, and she and her family are outstanding advocates, both community at the rare level, at every level. And I want you to know that that advocacy is happening. Um, I think it starts with listening to the lived experience of rural Oklahomans and other rural advocates, and ensuring those lived experience don't just inform the conversation, but help shape what comes next in care access and policy. That we're thinking about rural, and we're thinking about mobility, and we're thinking about all of those pieces, no matter where we're advocating at the community, state, or federal level. And that's all I've got.
Thanks so much, Sky, for an excellent presentation on Oklahoma Rare. We already have some questions in the Q&A portal for you. We'll get to those at the end. If anybody has any more
Okay.
questions for Sky, feel free to drop them in the chat or in the Q&A box. For now, we will move over to and here's Sky's slide on
Oh,
just
I did
some
forget about that.
yeah, her
If you'd like
socials.
to contact us, you can reach out here.
Yeah. Yes. And we'll also be posting the webinar on our YouTube channel. So if y'all would like to take a look at any of these slides or the slide again and connect with Sky, you'll be able to do so real soon. For now, we will shift over to our final presenter of the day, Shay Linton from South Carolina Rare. Shay?
Hello, everyone. I'm very excited to be able to share my experience and all about South Carolina today. I'm very happy to be able to be along some of my favorite advocates, Abby and Sky. I've known them for a good while, and I'm very happy to be there with them. So if I can get the next slide, please. Um, so kind of starting off, I actually am a rural person myself. I have grown up in a rural area my entire life. Now, being at the age of 23, I have learned a lot from living here. It's just kind of give you a little background as someone that was raised with this. So you can see on the map, I'm actually at like a county line in between two different counties, and to kind of give you an overview of how it was growing up. So the town that I live in, even though I live outside of city limits, is about 430 people approximately. So you have to imagine that's a very small amount of people. The county actually is around 45,000 people. However, that county is very much spread across towns and towns and towns. So a lot of times, you ride by, you kind of, as you can see in this picture, you think a lot about when you think of like the country, you think of Chesterfield County. You see fields everywhere, you see animals, all these different things, trees everywhere. However, I think it's important to realize the different things I'll talk about a little later. Whenever, like growing up and becoming diagnosed with a rare disease, there were certain things that were very much impacted, especially being rare. So when I have to travel to, say, like a medical facility, I have to travel 45 minutes minimum one way. When we have to travel for even more specialty care, we're having to travel hours and hours out of, away. We're having to travel out of state, different types of things. So I'll dive a little deeper into that. Just kind of give you a little bit of an overview and just kind of put it out there about how there are certain things that I think people don't really think of until they really, really dive deeper into rural. So, next slide, please. So just to give an overview of South Carolina, so we have approximately 5.5 million people within the state, and it's estimated because rare is typically 1 in 10. It's estimated that we have about 550,000 individuals living within South Carolina with the rare disease. And so just to kind of give you a little bit of an overview, a lot of people know of the South Carolina women's Gamecocks, the basketball team, of course. And so you can see the Colonial Life Arena here. That is a place that just gets talked about a lot. We actually, if you filled every single person in South Carolina had a rare disease in that arena, it would be filled over 30 times. So you just think about how popular that is and how that's a lot of people. So we can keep going. And just to kind of get a little bit into South Carolina Rare and why I decided to establish our organization. So I really felt like growing up, a lot of times the rare disease community is very disconnected within the state. You tend to have events and, organizations that are housed in about 4 different parts of the state, all of them being far away from each other, and everyone else kind of gets left out. I really felt this when I got diagnosed with rare because it was about a year and a half after I was diagnosed with my first rare disease before I ever met another rare patient. And that wasn't even within South Carolina. That was through the Everlight Foundation. And so some of our areas that we really focus on is we make sure to provide resources and education. We make sure to encourage people if they want to participate in legislative advocacy through stuff like Rare Across America or Rare Disease Week or whether it be state advocacy. We make sure to educate on clinical trials and research because we understand that not everyone has a background in that. Not everyone has ever been educated about that. We want to make sure they know they have access to that. We also want to make sure that we are intaking patient stories, we're hearing their stories, and we are sharing them so that people feel like they are being recognized, that they are, it's very important to share these because patient stories are why we are here. And then we make sure that we educate on newborn screening, that people understand, because that is something that people see every day, in a hospital, yet people don't truly understand necessarily how deep it goes and why we do have newborn screening. And then lastly, we want to make sure that people throughout the state know the involvement opportunities that are available to them, whether that's through organizations that already participate in the state, whether that's through organizations outside of the state. Just make sure that people know that there are ways to be involved in whatever capacity they want to be. You can skip to the next one. So our coalition stakeholders, we are accepting to anyone that is interested in learning more or participating in the rare disease community, whether that be patients, caregivers, family members, advocates, students, healthcare professionals, patient community organizations, community leaders, scientists, researchers, and pharmaceutical or biotech companies. So essentially, if someone is interested in learning more, then we want to make sure we include those voices because we know that by everyone coming together and learning more about rare, then we will have more awareness brought and we will have more change brought to this community. Next slide, please. So to kind of get into some very South Carolina specific things, so when we're talking about rural healthcare, we have to acknowledge where healthcare actually exists within the state. And so in South Carolina, how it is we typically have small community hospitals, also known as rural hospitals. Most of them, there has been a problem in the past where a lot of them either have closed or they're at risk of closing unless a major system takes them over, which has happened in some of these places, such as Florence. And so as you can see on the map, we have 4 places that tend to be major healthcare hubs. Florence is one that kind of represents for the PD region. A lot of people still have to travel far away. However, it is still not at the level of other places like an academic center, whereas it tends to lack in like pediatric care and stuff. So people have to travel farther away from that. And then you have Charleston, which has one of our major health centers, along with Greenville and Spartanburg and Columbia. So a lot of times what happens is people have to travel hours and hours away to seek care at these places. And if they don't have specialists, which many, different specialties still do not exist within the state, then they have to travel outside, then have to focus on the insurance coverage and different types of things as Sky has mentioned. So just kind of an overview. You can definitely see there's kind of like 6 counties that are covered within these healthcare regions, and then it's kind of like everyone else is left out. So in South Carolina, you have 46 counties in total. So you have about 40 that have to travel out of county and to seek care. So next slide, please. So today I wanted to really look at the things that most impact the rural residents in our state through the idea of the pillars of the social determinants of health. And so when you think of social determinants of health, there's typically 5 pillars that we think about. You think about economic stability, education access and quality, healthcare access and quality, neighborhood and built environment, and social and community context. So I think this is very important because a lot of these pillars end up interacting with each other. You can't just have one or the other. Everyone tends to be impacted by every single one of these. And so to kind of like dive a little deeper into what most impacts rural residents, when you think about economic stability, a lot of times in rural areas, you'll see that people have higher poverty rates and lower household incomes. They also tend to have less access to job opportunities. When you think about places, say the one I grew up in, there is no public transportation to be able to get, to a job opportunity. A lot of times you have to travel towns and towns away and, to just be able to find different job opportunities. So I think it's very important to recognize that um, to think about the impact that has, especially when you have multi-generational homes and how, a lot of people are trying to be able to find jobs and then just what that takes to be able to truly even just go and seek that. The other one is education access and quality. This is a really big deal because I think it doesn't just extend into rare, it extends just, it kind of takes over and it's very much a multi-generational thing. So when we think about this, you may have a lot of people that graduate high school, thankfully. However, a lot of times the focus is less on getting a college education or a graduate school education. It's more on going straight into the workforce. Many people, because their families are, they don't have access to jobs and they're in poverty, a lot of people very much go into different trades and stuff like that. And so it's very much like it's a great thing that they're going into trades, but however, people don't tend to be pushed to go into something with like educational opportunities. So a lot of times you end up having people that they don't have access to stuff like STEM education and stuff, which may be helpful in a rare context. I think this goes a little deeper because when you think about stuff like, say, genetic testing or research, a lot of people have never been exposed to this. They don't know that this is something that may be available to them. They may not know that that may be helpful in their context. So I will tell you, like in my experience, I was raised around the healthcare system. My mother's a nurse. I've been around her my entire life and seeing how she works and engages with the healthcare community. However, when I became a rare patient, I was never specifically asked or, even taught about genetic testing. And so that shows how even if you have a background in education with like healthcare, it doesn't always, it's not always provided for you. So it's important for people to be taught these things. The other thing is I think a lot of times people don't have access to know that they can represent themselves in a legislative advocacy position. So a lot of times people don't know that they can go to the state house, they can talk to the representative. And so I think there's just different ways that being able to kind of like teach these things could help people and it could go through generations. The other thing, and I really feel like this is a big deal, as I talked about earlier, is the healthcare access and quality. So, as Sky mentioned about the healthcare provider shortages, we have almost every county in our state has a healthcare provider shortage. The county I live in has actually had the designation since it was literally made decades ago, and it has never changed. So, it's just very important because a lot of times we don't actually have physicians here. Thankfully, we have nurse practitioners that will come to the area and practice. However, it tends to be people that come here, they will practice for a long time. And then whenever that person decides to retire or go somewhere else, then you have a gigantic hole in the system because they have taken care of so many patients, had a huge workload, and then that is now gone. And so I think it's very important. The state has been working, there's been a lot of bills focusing on trying to impact this provider shortage, trying to prevent rural hospital closures and kind of bringing new people in. So hopefully that will be continue to be pushed through the government. However, that is something that definitely needs to be worked on. It goes even further when you think about rare rural healthcare, because when you think about having to go and see a specialist, there are not many specialists anywhere in these areas. And so I think it's just a big problem because then you have to travel, and it's not only for specialty care, you have to travel to be able to have access to different like diagnostic tests to be able to have imaging and all these different things. There are times where when you go deeper into say like labor and delivery, there are not places to deliver anywhere near, and then you go into different factors, which I won't get into all of those, but just to point out. And then kind of going into neighborhood and built environment. So, like I said before, there's definitely a lack of access to transportation. When you think about it, like recently in the past few years, there has been established public transportation. However, it still does not go out to the most rural of areas. When you're thinking about these communities and these roads that people live on, they're not going there. So I think just being able to kind of change that and make sure, because then that impacts other things of being able to access food, being able to access job opportunities, being able to access healthcare. And so the other thing is food deserts. So a lot of times we are very much a lack of healthy food. People that are on dietary restrictions, I think this is a big problem because when you can't go and say, like, you may have one grocery store in the entire town, if you even have a grocery store. And so like the one I grew up in, we just got a Dollar General, and if not, we have to go 15-20 minutes away one way to get groceries. And that's to say, what if it's busy? What if the food's gone? Then you have to travel further to get to that. And so I think it's just a really good point, because people, especially, rare patients that may have dietary restrictions, they have to be able to access this food because that is part of your livelihood. That is part of how, you go about day and day. And so the other thing is social and community context. I think a lot of people, when they think of like small towns, they think of rural areas. It is very much a community like place. People are very connected. It's very much like people talk word of mouth and stuff. However, when you have these really rural areas, when people go home, they're very much isolated. When they're not in a public place together, they are isolated because they tend to be like, you will not have neighbors very far, far away from you, right? Like it's not like a neighborhood that you would think of. And then when you think of something like broadband internet access, thankfully, South Carolina has started to get better on this, and they are increasing their amount of people with broadband internet access. However, when you think of stuff like telehealth, as Sky was talking about how some patients and families really benefit from telehealth, not everyone can do that. And so I think it's just important to remember that that's not always an option for someone, and that is something that, even if they have internet access, they may not have a phone, or they may not have access to, a computer or anything like that. So I just think it's something very important to focus on. Okay, next slide, please. And just to kind of end, I wanted to really talk about kind of rural advocacy and the ways that I feel like we can better like build a community with this. And so the first thing is building trust should be your number one priority. Trust is literally what community is built off of. So when I think of talking to people that, are rare or non-rare, I really feel like it's important to meet people where they are. You have to level set. You have to understand what they know about rare. Because a lot of people, and this kind of goes off the point later on, a lot of people don't know what rare is. They think, oh, I'm over here. I'm not rare. I don't know anyone that's rare. And so it's kind of like they distance themselves from that because they don't think there's a similarity. And so for me, I like to really point out more popular known rare diseases. So stuff like, almost everyone years ago heard about the ice bucket challenge for ALS awareness. Everybody heard of that. People all over my town were doing it. However, you can kind of relate that back and be like, you do know about rare because you've participated in this, and that was. I know in South Carolina, we have a lot of sickle cell clinics. We have a lot of sickle cell organizations. And so when people hear sickle cell, they don't think rare necessarily, right? They just think, that is, a disease that I may know someone that has. And so I think just kind of like talking about these things and really like meeting them where they are and saying like, this is something that impacts everyone and it can impact anyone at any time is very important. I think the other thing to really point out is you have to take into account that exact person's beliefs and their experience. So a lot of people, they may not feel comfortable talking about healthcare. They may have grown up in a family where people were like, we don't really talk about our health. That's kind of like a stigmatized thing. And that's completely okay because that's what they grew up in. I think that's important to know that they ever feel like they want to share, that they have that space that they can in a safe way. Because I think it's very important because when we think of people that are different, one thing that connects all of us is healthcare. Everyone gets sick at some point in their life or knows someone that is sick. And so I think that's important because it's kind of like a community building thing and everyone understands that in some type of capacity. I think another way to engage communities is to look into non-rare specific spaces. So like in kind of small knit communities, rare rural areas, you have different places like libraries. People don't think of the libraries. Like in my library, in my small town, I said it was like 450 people. They had like 60 people last week for an event for summer reading. Okay. Like they don't play about public spaces. So I think it's just very important you'll have like church events and stuff like that. That not necessarily like even if someone isn't comfortable with the religion or anything, there's still sometimes open spaces where the community can come in. And I think that's important to be able to recognize like these are places for you to build trust with people and kind of be able to talk. I think the other thing is like local events. So I once had a person tell me that they went and they educated people at a rodeo. Like they had never thought about it. They were like, that's somewhere that people go all the time. And I was like, that's a great idea. So just kind of finding those local places that maybe you wouldn't think, oh, I'm going to learn, but people may be open to engaging with you. And the last thing is just talking about statistics. So, not like the very advanced math class statistics, but just kind of making sure people understand how rare is. You think about rare disease and you hear the number like every 1 in 10 people have a rare disease. That gets to people, right? When you think about how 95% of all rare diseases do not have a treatment, people understand that, right? And so I think just make sure you share that in an applicable way to that person's situation. I think that's very important. So, and these are just a few ways that I feel like are helpful. Next slide, please. And this is just a little bit of information on how to contact me or South Carolina Rare. And you can scan the QR code to be taken to our website and learn more about us. So thank you.
Thanks so much, Shay, and thank you to all of our presenters for giving these fantastic presentations. I'm going to shift over to questions. If you all do have more questions, just feel free to drop them in the chat. But right now we've got two each for Sky. First, I'll go to Mary's question. Sky, how do you identify gaps in the system?
Um, how Oklahoma Rare identified them for those slides, excuse me, is we partnered with organizations in the state to hold a rare disease town hall. So we just listened to families, to patients, and we noted what everyone was saying, where the common themes were, what we were seeing, and what was a shared theme, and that's how we came up with those highlights.
Excellent. And then I've got another question for Sky. Are there data collection tools that can be shared with organizations like NFED that want to conduct a needs assessment survey of their community?
Let me see. That may be an RDLA question. Abby, do you want to jump in on that one?
I don't know if I know off the top of my head, but I can look into what some other organizations have done. Needs assessments are pretty common. I know Q&A is kind of a weird format to ask this question, but in follow-up, are you specifically looking at like the needs assessment for rural versus just like a general
I think in this
rare
con
disease?
and I think in this context, we could say yes.
Okay. Yeah, I can look into just ask around some of our organizations and see if I can get back to you on that one. I think states are doing it a little bit differently. Like Sky said, I think the listening was really the key piece to getting some of these gaps is really just like a listening session. But I know for organizations that are more spread out, it's a little bit harder to host something like that.
And we've not done a formal needs assessment survey or any data collection in Oklahoma. We may do that, but we haven't done that yet.
Yeah, great question. Kristen, I wrote down your name and I'll definitely pull up your contact to see if I can follow up.
Sounds great. And I also just dropped my email in the chat in case folks have any additional questions. You're more than welcome to reach out to me and I can connect you to our presenters here or help you find the answer. Please, before you hop off, stick around for just a couple of important announcements about future RDLA programming. First, please save the date for our next RDLA monthly webinar. It'll be on Tuesday, June 30th at 2 to 3 p.m. You can learn more and register at rareadvocates.org/webinars. And then here's the big one. Please remember to register for Rare Across America, which will be August 10th through the 21st of this year. Registration will close on July 17th. This is an excellent event meant to connect you with your members of Congress in their district offices to discuss some important rare disease issues that are affecting our community. To learn more and register, just go to www.rareacrossamerica.org. If you would like to connect further, you can sign up for our newsletters action alerts and get more event invitations at rareadvocates.org. Our socials are here in the slide. I will be posting this webinar on our YouTube channel and on our website. And so please look out for that in over the course of the next week. And if you have any questions, I dropped my email in the chat, but you can always reach out to me, the State Advocacy Manager for Every Life, at sejaws@everylifefoundation.org. Thank you so much for being a part of our webinar today, and thank you to our wonderful panelists and presenters. And with that, I will close this out. Thanks so much.
Thanks, everyone.
Thank you.